Dr. Jain, are you with us?
Yes, sir.
Jain, you can switch on your PowerPoint. We are able to see you well and hear well. And I'll request Professor Nishikant and Professor Karnakaran to start the questioning after she presents the topic. Dr. Ishwar Hosamani is expected to join shortly. In the others, I think I'm just sorting out one of the other challenges of the password with them soon. So let us start the session on time so that the others who are around waiting may not be disappointed. Nishi sir, please take over. By the time I will sort out the remaining faculty's password issue. Kanna sir, good evening, sir. Good evening, sir. How are you, sir? You're keeping well, sir? Sir, you are in mute mode, sir.
Yeah, I'm better now. Yeah, I'm better.
You're all right, sir. You're looking better now.
Yeah.
Right, sir.
Yeah.
I could see Professor Sunil. Sir, can you identify yourself, sir? Okay, I think he's not able to hear us. Nishi sir, you please start the presentation. We have
yes.
Kanna sir here. And Jane, please introduce yourself, your unit chief, your head of the department, and start your presentation.
Sir, my screen sharing, sir.
You're not able to do?
1 second, sir.
You find it difficult?
1 second, sir.
Yes, we are able to see your thing, but we are able to see your slides. There you go.
Sorry, sir. 1 second.
No problem. You just did it right. Just leave it like that. Make it full screen if you have, you can play that. Otherwise, this is also fine.
Yes, sir.
Please go ahead. Faculty, please take over.
Good evening. I'm Dr. Jane Priya, second year postgraduate from Sri Ramchandra, Chennai. My unit chief is Professor K. Balaji Singh. I'm here to present about a 43-year-old gentleman who came to our OP from Chennai, a driver by occupation, with a persistent ulcer on the right side of the tongue for the last 4 months. He says he noticed a small ulcer on the right lateral border of the tongue 4 months ago. He was not sure how exactly it started, but he was sure that it gradually kept progressing to the current size. He complained of pain at the site of the ulcer in the last 3 weeks, which was dull and continuous in nature and aggravated while talking and eating. And in the last 1 week, he also complains of pain at the right ear. He also gave history of noticing to frequently keep spitting, probably due to hypersalivation. He did not notice any obvious foul smelling from the mouth. There was no difficulty in speech or eating. There was no pain on protruding the tongue. He did not notice any white this lesion. There was no voice change. There was no recurrent attacks of mouth ulcers that he had. There was no history of bleed from this lesion. There was no altered sensation of the tongue. There was no numbness over the lower lip or chin. He did not give history of noticing any other swelling in the neck. There's no history of loss of weight or persistent cough. In the past history, he did not give any history of visiting the dentist for a sharp tooth or any recent tooth extraction. He was a newly diagnosed diabetic. And other than that, he did not have any comorbid illnesses like systemic hypertension, tuberculosis, or any asthma in the past. Personal history, He consumes a non-vegetarian diet. He did not specifically, when asked, he did not say that he likes to have a spicy meal. It was a normal spice that a South Indian would have. His sleep pattern, because of the pain, was affected in the last 1 or 2 weeks. Other than that, his sleep or appetite was not disturbed. He is a non-smoker. He did not give history of consuming alcohol or tobacco chewing. Family history, there was no malignancies, especially head and neck malignancies in the family. So summarizing the history, we had a 43-year-old male with a non-healing ulcer on the right lateral border of the tongue, measuring, he says, it is kept progressively increasing in size in the last 4 months with referred otalgia. That's my history, sir. Sir?
Please go to the first slide, ma. Kanna sir and Nishikant sir will take you to the questions. We have Professor Srinivasan sir and Karnakaran sir also available.
Yes, sir.
Faculty, please take over, sir.
I am having something problem with my computer.
But we are now able to hear you, I think, sir. Are you able to see the slides, sir?
No, I'm not able to see the slides. That's what I was trying to get it.
Madam,
Yes, sir.
Priya madam, what is complaint?
His chief complaint was an ulcer, noticing ulcer in the tongue, sir. Right side of the tongue.
Non-healing ulcer.
Yes, sir.
So your chief complaint should be in a patient's language.
Yes, sir.
Your chief complaint should be in a patient's language.
Okay, sir.
Maybe a better word
Don't
is
mention
long-standing
non-healing.
ulcer, something like that. Will that be fine, Nishi, sir?
Long-standing ulcer.
Long-standing ulcer.
Sure, sir.
Kanna sir, I have put the PowerPoint in the group also, sir, in the PG Clinics faculty group. If you have Are you able to see the slides, sir?
I will come on my other computer, Jane. I will.
Please,
Okay,
sir, please. Please go ahead, sir. Nishi sir and Srinivasan sir, please take over.
Any other?
Put your next slide, ma'am. Put your next slide.
Yes, sir.
Yes, next.
Yes, sir.
You put pain on tongue protrusion. Is the tongue
Yes, sir.
protrusion normal?
Sorry, sir.
You put pain on tongue protrusion.
Yes, sir.
So that what is the tongue protrusion is normal?
Sir, specifically asking if on tongue protrusion, if there is any pain, he denied the history, sir.
What is
Did she say that I'm able to protrude my tongue? Yes, sir, Nishi sir, please.
Yes, sir.
What is significance of pain on protrusion of the tongue?
Sir, if
What is significance of pain on protrusion of the tongue?
If the palatoglossus is involved, there can be
Why
pain
you ask
on-
history of pain on protrusion of the tongue?
Sir, having malignancy in mind to rule out infiltration of the
Pain
muscle.
on protrusion is correct terminology or inability?
Sorry, sir, I couldn't hear you.
Okay. Malignancy causes pain.
In the late stages, it
Malignancy
can cause.
causes pain.
But this
Yes,
is
sir.
only 4 months. This is only 4 months, you said, isn't it?
Yes, sir. If there is involvement of tongue musculature secondary to ankyloglossia, there can be pain, sir.
What do you think are the muscles of the tongue? What are the
Sir,
Intrinsic muscles?
palatoglossus, extrinsic and intrinsic muscles, sir.
Hmm.
Palatoglossus, genioglossus, styloglossus, and then the other one will be vertical longitudinal muscles, sir.
So you have an extrinsic and intrinsic, isn't it?
Yes, sir.
Hmm. Which is the muscle which protrudes the tongue?
Palatoglossus, sir.
Palatoglossus.
Sorry, genioglossus, sir. I'm sorry.
Which is the muscle which protrudes the tongue, which is again, it's see, the tongue inside is small, but when it comes out, it's a bit wider. Which is the muscle that protrudes it and makes it bigger?
Genioglossus, sir.
Genioglossus is a fan-shaped muscle, okay?
Yes, sir. Yes, sir.
So Sir was asking why you get pain on protrusion of the tongue.
Yes, sir. Involvement of genioglossus, if the muscle is involved due to malignancy, there can be pain.
Why you ask for history? What is halitosis?
So foul smelling, bad breath from the mouth.
Pardon?
Bad breath, sir. Foul smelling.
Why is it due to?
Sir, if the tumor necrosis, then there can be release of mercaptan and ammonia related substances which can give the bad breath.
There's hypersalivation, stasis.
Yes, sir.
And you had asked for dysphagia and dysarthria. Is it common in a dysphagia? Is common in dysphagia. Arthria is common in CA tongue.
So if the posterior part of the tongue is involved, or if there is again ankyloglossia, there can be difficulty in speech, and because the tongue movements get involved, there can be difficulty in both these.
Posterior and third growth is when the posterior aspect is involved.
Both these can be expected, sir.
Or the growth extends posteriorly from the anterior aspect. You will have, because of the weight and the fixity, you will have dysarthria and mild dysphagia. Okay.
Yes, sir.
Pain on the white or red patch prior. See, certain history should come in the front. Certain history should go back.
Okay, sir.
See, halitosis, right? Pain on tongue protrusion, right? White or red patch prior. What do you mean by the white or red patches?
Sir, erythroplakia or leukoplakia, if there is any anything that he noticed before having noticed this lesion.
What is the importance of asking for erythroplakia?
Sir,
or leukoplakia?
Sir,
are they pre-malignant conditions or
pre-malignant conditions, sir?
சார் இன்னைக்கு 3ஆம் நாள் தானே?
அப்புறம் வர கீழே
இந்த நாள் ஜுரம் வந்தது. இன்னைக்கு 3ஆம் நாள்.
Why you ask altered sensation?
Please, sir, please take over, sir.
Sir, if the lingual nerve is involved, there can be altered sensation of the tongue, sir.
So now tell me what is nerve supply of the tongue?
Yes, sir. General somatic sensation will be from the lingual nerve, sir. And taste sensation will be, this is the anterior two-third. Taste sensation will be from the chorda tympani. And posterior part will be from the glossopharyngeal nerve, sir. Posterior one-third.
And one more point, you have mentioned that there is numbness, no history of numbness over the lower lip and chin. What is the clinical significance?
Sir, if there is involvement of the inferior alveolar nerve, then we can somebody can have numbness over the lower lip or the chin, sir.
But where is the lesion? On lateral aspect of the tongue?
Yes, sir.
Any other positive history?
Sir, other than this referred otalgia and the persistent ulcer, which has been progressing to this extent.
Explain why there is otalgia.
So otalgia, the tongue is supplied by the lingual nerve, and the ear is supplied by the auriculotemporal nerve. Both are branches of the posterior division of the mandibular nerve, sir. So there can be referred pain to the ear,
ஏற்கனவே
sir.
கொடுத்துருக்கம்மா, அதெல்லாம் போடுங்க. கொடுத்த மாத்திரையை போடுங்க.
What is clinical significance of white patch or red patch?
Sir, pre-malignant lesions like leukoplakia or erythroplakia can predispose
What
somebody
is
to.
definition of leukoplakia?
Sir,
WHO definition.
leukoplakia is
no.
a white patch, sir. Any white patch or plaque that cannot be characterized clinically or pathologically as any other disease.
Erythroplakia.
How many types of
Erythroplakia is.
leukoplakia? How many types of leukoplakia?
So leukoplakia, there can be homogeneous or speckled leukoplakia, sir.
Which is more
Speckled leukoplakia is more. It's the risk factor is more with that type, sir.
So if you have a leukoplakia, what is the course of the leukoplakia? What can happen to the leukoplakia?
It can progress to a malignant lesion, or it can regress completely also, sir.
It can progress or regress, or it can persist.
Yes,
That's the
sir.
same.
Yes, sir.
Okay. How do you treat a leukoplakia if the patient had a leukoplakia?
Sir, I'm not sure.
No, sir. Dr. Ratna madam is there. Madam, you can take over if you want.
Yes, I'll just take over in a few seconds. Yeah.
Yeah, madam. Please, madam. Welcome, madam. Okay, go to the next. Go to the next slide. You were
Yes, sir.
asking.
Summary.
No, the previous one.
So,
previous one.
Yes, sir.
The previous one.
So from your history, what do you think? Is this ulcer a benign ulcer or a malignant ulcer?
Ma'am,
Welcome, madam. Welcome,
Thank
madam.
you, sir. Thank you, sir.
Welcome.
Yeah. Yes, Dr. Jain.
Yes, ma'am. The very fact
Madam
that
is
it's
asking for the
been,
history. Is it benign or malignant?
I feel it's malignant only that we should be considering, sir.
Yeah.
No,
Because of the
should
fact.
be concentrated.
Yes,
What are
give
the
us
points to say?
just narrate the points in favor of it being a malignant lesion.
Yes, ma'am. Persistent non-healing ulcer for the last 4 months, which has not shown any signs of healing, and associated with referred otalgia.
Yeah.
Are the only significant points in my history to suggest malignancy.
Yeah. So there are features that are suggestive of infiltration into the nerve. So you think it's a malignant lesion.
Malignancy.
Yeah. What are the respiratory symptoms that you wanted to ask from the patient? Does the patient have any respiratory problems?
Any persistent cough, or because I think if there was aspiration because of the hypersalivation, or so cough.
I hope you took that history.
Yes, ma'am. I have cough. I've written in notes, negative history.
Yes. Any history of frequent bleeding from the ulcer?
No bleeding at all, ma'am. That he noticed at least.
I think you've taken a good history. We should proceed to examination.
Okay.
Yeah. You had asked about the personal history?
Yes, sir. He is not a known smoker. He's not a smoker. He denies history of
nothing is there. Nothing is there. Okay, right. Go. Your history is good.
Yeah, what is field cancerization?
Sir, exposure of toxins to
What is field cancerization?
Yes, sir. Exposure of the toxins, carcinogens to the aerodigestive tract can cause lesion anywhere in the oral cavity.
And what is the chance of having the synchronous cancer in the oral cavity?
There is a 10 to 20% chance of a synchronous malignancy that can happen in oral cavity cancer, sir.
What are the various viruses which can cause the oral cancer?
So
Or
human
may-
papilloma virus and Epstein-Barr virus, sir. And although it's uncommon now, syphilis also has to be kept in mind.
Mhm. So how did you take the history of the HPV?
Any so sexual history, sir, honestly, I did not ask, but it should be kept in mind, sir.
Mhm. And somebody says that I got lot of warts on my body.
Okay, sir.
Yeah, okay. So what is the difference between a HPV positive cancer and HPV negative cancer?
Sir, I have to read. I don't know, sir.
You know, what are usually HPV positive cancers? Where are they? They're usually on the posterior side, okay?
Okay, sir.
So like the posterior third of the tongue is there, or in the pharynx is there, then it is more likely to be HPV positive one, you know?
Yes, sir.
Lymph nodes are enlarged, but somehow the prognosis of these patients is better than the HPV negative.
Okay, sir.
Total outcome is better in the case of the HPV positive.
Yes, sir.
So in case of leukoplakia, what are the various leukoplakias which are likely to cause the malignancy?
Sir, speckled or nodular type of leukoplakia is more dangerous, sir.
And is the erythroplakia more malignant or leukoplakia? Is more?
Erythroplakia is more malignant, sir. Pre-malignant, sir.
What are other pre-malignant conditions of the oral cavity cancer?
Sir, chronic chronic hypertrophic glossitis, erythroplakia, and leukoplakia. These are the precancerous conditions that we have to keep in mind. And these are the pre-malignant. Precancerous conditions would be Plummer-Vinson syndrome, syphilitic glossitis. I can't think of the other ones. Discoid
Any fungal infection?
Hairy leukoplakia. Sorry, oral candidiasis.
And yes, yeah, okay. Okay, I think you can go on the examination
How
now.
do you differentiate candidiasis from leukoplakia clinically?
The scraping of the lesion.
Yeah. Proceed to examination.
So the patient was examined in a well-lit room after getting consent. He was conscious oriented. His hydration status was maintained. His ECOG score performance status was 1. He was afebrile, not tachycardic. He had a normal respiratory rate. BP was 120/70. Saturation of 99% in room air. There was no pallor, icterus, cyanosis, clubbing, or generalized lymphadenopathy. I'll brief on this in my examination, or pitting pedal edema. This was the lesion. So on inspection, the mouth opening was adequate. There was no facial asymmetry that was noted. There was no tongue deviation. There was no tobacco staining of the tooth. There was no halitosis. His dental formula didn't show any missing tooth. A single oval-shaped ulceroproliferative lesion on the right lateral border of anterior two-third of tongue, measuring around 4 into 2 centimeters, extending from the level of lateral incisor to the third molar posteriorly, and medially 2 centimeters away from the midline. The edges were rolled out and everted. The surrounding tongue appeared normal. There was no active bleed or discharge. There was pooling of saliva that was noted. There's no white or red patches noted. The tongue movements appeared normal, and rest of the tongue and the oral cavity, including lip, palate, gum, buccal mucosa, appeared normal. On palpation, an ulceroproliferative lesion on the right lateral border of anterior two-third of tongue, measuring 4 into 2 centimeters, tender, did not bleed on touch. With the bed, sorry, I did not mean to say surface. The bed was uneven and the margins were irregular, with surrounding induration of 0.5 centimeters extending to the floor of the mouth. The induration did not reach the midline, and the lesion also was not crossing the midline. There was no other palpable lesion in the cheek, lip, retromolar trigone, or posterior one-third of the tongue. There was no mandibular thickening. On examination of the neck, there was a almost 1 into 0.7 or 1 into 1 centimeter non-tender mobile firm node in the right level 2 region. There were no other palpable nodes in the neck. Systemic examination, cardiovascular, respiratory, abdomen, skull, and spine were normal. Summarizing, a 43-year-old gentleman with a non-healing ulcer on the right lateral border of tongue for the last 4 months with referred otalgia, with no background history of smoking, alcohol, or tobacco chewing. On examination, showed a 4 into 2 centimeters ulceroproliferative lesion with everted edges, with induration extending to the floor of the mouth and not crossing midline, with ipsilateral sub-centimeter level 2 node.
So
Yes, sir.
what is significance of crossing midline?
Sir,
Not crossing midline.
Our treatment plan would change depending on that. If the lesion crosses midline, then we have to plan a more aggressive resection. If it is staying within the midline, we can stick to planning hemiglossectomy.
Any other point? If growth crosses midline, then what about the lymphatic drainage of tongue?
So lymphatic drainage, the tip will go to submental, sir. Lateral border will go to submandibular and upper deep cervical. Posterior one-third will go to bilateral deep cervical nodes, sir, and jugular digastric and jugular omohyoid.
So which one is bilateral? In which condition you will get the bilateral?
Posterior one-third if it's involved, sir.
Okay. Then which lymph node is present in your case?
So level 2, sir.
Level 2. What are the levels of lymph node?
Sir, the submental. The 6 levels of lymph node, 7 levels of lymph nodes, sir. Submental level 1 and level 1A, level 1B will be submandibular. Upper jugular, middle jugular, lower jugular will be 3, 4, 5, and anterior neck will be central. That is level 6 and
neck.
Sir.
Okay. Proceed. Anterior neck. What you told just now? Anterior neck lymph node.
Level 6
or
would be.
Triangle?
Yes, sir. Yes, sir.
Yeah, what is level 6 lymph nodes?
So the anterior medial to the sternocleidomastoid on the lower part, sir.
So which type of the head and neck cancer will lead to the level 6 lymph nodes?
So, papillary carcinoma of thyroid, sir.
Okay. And level 7?
Internal mammary nodes, sir.
No, they are not internal mammary nodes.
Madam, what are the
part of the
triangles
retrosternal area, no?
Sorry, sir.
In the lower part, in the retrosternal area.
Retrosternal, yes, sir.
Madam, what are the triangles of neck?
Sir, anterior triangle and posterior triangle, sir. Posterior
What are the-
triangle,
What
yes,
are the
sir.
boundaries of anterior triangle? What are the boundaries of posterior triangle?
Sir, the anterior triangle
And
is
subdivision of
boundaries would be lower part of mandible and the posterior belly of digastric, sir. And posterior
anterior
triangle,
posterior belly of, wait, madam. Anterior belly, posterior belly of digastric.
mandible and anterior belly of digastric, sir. Sorry.
For the anterior triangle?
Boundaries
Sir?
of anterior triangle.
Anterior
Length and
triangle,
length.
posterior border will be sternomastoid, sir. And lower part will be omohyoid, sir.
Wait, madam. What are the boundaries of? I'm
Cannot be
asking what
defined.
are the boundaries of anterior triangle? I'm not asking the subdivision of the anterior triangle.
Just tell about the anterior and the posterior triangle
And
first.
posterior triangles.
Sir, I'm not sure.
This is basic
No,
question,
anterior
madam.
triangle is lower border of the mandible, which is there. Midline
Yes.
is there. And
Yes,
then
sir.
the
Anterior
sternocleidomastoid.
border of sternocleidomastoid.
And
Yes,
It is
posterior
again
triangle?
divided into 4 parts. It's again divided into 4 triangles by digastric and superior belly of omoid.
Yes, sir.
What are other triangles, sub triangles in that anterior triangle?
I'll read up, sir.
Submental, submandibular, muscular, and carotid.
Yes, sir.
Okay.
So you mentioned that growth is extending to the floor of the mouth.
Yes,
What
ma'am.
significance do you attach to that?
We have to look at the depth of invasion. So the staging
You
would.
said induration is extending till the floor of the mouth.
Yes, ma'am. So
So do you think this induration is inflammatory induration, or do you think it's a malignant infiltration?
we have to consider malignant induration.
Yeah, anything that extends beyond the margins of the lesion is more expected to be due to malignancy. So what importance do you attach to that?
If the depth of the lesion extends to the musculature, then the staging of the disease is advanced, and then we have to plan our treatment accordingly.
Yeah, that's true. And then the areas where the growth can extend from here can also be different. It can extend to the mandible from here.
Yes,
Protrusion of tongue may get affected. Submandibular duct may get affected. So there are other parts of the.
yes, ma'am.
You mentioned about the dentition, but you never told us if there is any sharp tooth or not.
He on palpation also there was one tooth which we thought it gave him any prior history, but he denied saying that tooth was
On
bothering him.
examination, you didn't find any sharp tooth.
No, ma'am. No, it wasn't sharp.
Yeah.
Madam, what are the differential diagnosis of ulcer over the tongue? This is commonly asked question.
Yes, sir. It can be if it's benign, it can be aphthous ulcers, it can be syphilitic ulcers, and trauma due to sharp tooth or ill-fitted dentures, and it can be gummatous ulcer or carcinomatous ulcer, sir.
How aphthous ulcer will present? What is presentation of aphthous ulcer?
Aphthous ulcers can be small but very painful. It can be single or multiple ulcers.
Gummatous ulcer.
Gummatous ulcer can initially be painless and in the later stages can be painful, sir.
In later
And
stages means
when the stage of the
in primary,
disease,
secondary or tertiary syphilis?
Tertiary, sir.
Tertiary syphilis. Or secondary
Here, what
syphilis.
are the various sites of ulceration in various type of syphilis? Where it will be in the primary, where it will be in the secondary, where it will be in the tertiary? Where do you get an ulcer in the primary? Where do you get the ulceration in the secondary? And where do you get ulcer in the tertiary?
Sir, sorry, I'm not sure.
Okay, primary is usually at the lips.
Okay, sir.
Okay, secondary is usually at the mucous membrane, so on the cheek.
Yes, sir.
And tertiary is usually on the palate.
Yes, sir.
Okay, and
Yes,
it can
sir.
occur over the tongue also, but usually over the palate.
Yes, sir.
So how you are going to proceed with that?
Sir, I would like to investigate. I would like to divide the investigations by confirmatory investigation and to stage the disease and to look at the general condition of the patient to plan for any procedure. So to confirm the diagnosis, I would like to do a biopsy from the lesion. And to stage the disease, I would like to get a contrast
From where you will take the biopsy?
From the edge of the ulcer, sir. Edge wedge biopsy is usually done. We can also do a punch biopsy from the lesion, but the biopsy should involve a part of the normal tongue.
So will
tissue.
you take it from the anterior edge or from the posterior edge?
Anterior, sir.
Why?
We don't want any this I'm not sure, sir, but if there is any bleeding, it can be tackled if it's in the anterior edge rather than blood or saliva getting pulled and chance of aspiration if we do it in the posterior edge.
Anterior you take because that is an easy area technically.
Yes, sir.
If the bleeding is there, that will be difficult to control on the posterior side.
Yes,
And then
sir.
also it is difficult to, when you're going for the resection,
Yes, sir.
if the more
can be
posterior one
included.
is there, then it is difficult to resect in that area. It
Yes,
is
sir.
always advisable to take a biopsy from the anterior edge rather than from the posterior edge.
Yes, sir.
What you will get in the biopsy report?
Sir, if the most common pathology expected is a squamous cell carcinoma. So if it's squamous cell carcinoma, we would look for keratin accumulation, which is seen as keratin pearls. And depth of invasion also can be looked at from the biopsies.
Yes. And what are the various other types of the malignancies which can occur over the tongue apart from the squamous cell carcinoma?
Adenocarcinoma is very rare, sir.
So from where you get the adenocarcinoma?
So minor salivary glands, adenocarcinoma is more common, sir.
Right. You know how many minor salivary glands are there in the oral cavity?
More than 100 to 200.
Even more than that, Yeah. Okay.
Okay.
So you said the squamous cell carcinoma, adenocarcinoma, any other malignancy which can occur?
Sir, don't know, sir.
It looks like a black color.
melanoma, sir.
Yes, melanomas can also be there. No?
Yes,
And then there can be mixed type of the tumors may be there.
yes,
Okay.
sir.
So you have done the biopsy, it has come out to be squamous cell carcinoma. Further, how you are going to proceed?
Sir, I would like to, because there's no, clinically there's no suspicion of bone involvement, I would like to ask for an MRI, contrast enhanced MRI, and to know the exact extent of the tumor and involvement of tongue musculature and to look for nodes, even though to look for nodes, MRI is not the best investigation, but this will cover enough to plan for surgery.
Now, how will you confirm that the lymph nodes are metastatic?
Sir, ultrasound guided FNAC can be done from the node because it's not a very big node in this patient. So guided biopsy is better to be planned. And after that, we can plan further, sir.
What are the ultrasound pictures of the metastatic node?
The shape of the node will be bean shaped. Any alteration itself can be a suggestion that it can be malignant. Loss of fatty hilum and irregular shape and taller than wider margins. And yes, sir, that's all I can think of.
Then you can add the Doppler to that, you know, and looking for the vascularity also. You know?
Increased vasculature, yes, sir.
Okay, so you have done the MRI, it shows that there is involvement of the floor of the mouth is there.
Okay, sir.
What next you are going to do?
If there is no bony involvement, I can still plan for hemiglossectomy with
You do not want to do any other investigations? You are not planning for any other investigations?
CT of the neck, sir.
Okay, CT of the neck can be done. Yes.
Yes, sir.
You know, investigations always in malignancy are in the three. Okay, one is to make a diagnosis.
Yes, sir.
Second is to look for the
Stage.
metastatic workup.
Yes, sir.
And third is
general condition of the state.
general. Yeah, so whatever you decide.
Yes, sir.
Okay. So still you have not done anything further. Third one, that what is the
Yes,
general
sir.
status of the patient here?
I would like to do blood investigations, including complete blood count, his albumin to look at the nutritional aspect of the patient, and then an electrolyte level, and if his.
Would you like to have an X-ray of the chest or not?
Sir, yes, sir. ECG and an X-ray we have to ask for. Sir.
X-ray of the chest for what?
Sir,
In
if we
CA
are
tongue.
Sir, pulmonary metastasis is rare, sir, but it can be a possibility. So if there is gross abnormality, X-ray itself can pick up changes. Sir.
Okay. So based on all this, what is your plan now?
I would like to offer hemiglossectomy with modified radical neck dissection, sir, on the same side. with,
So what about the floor of the mouth?
sir, this lesion for this patient, it doesn't seem to involve the floor of the mouth. But if the floor of the mouth was involved, then we have to plan for mandibulectomy also. So,
So in the case of the C of the tongue, are you going to address neck on both sides or one side only?
sir, if it is stage 3 or 4, we have to address the contralateral neck node also, sir. Even though clinically it can be N0, but stage 3 and 4, there's a 20 to 40% chance that no micrometastasis on the contralateral side can be involved. So we should think of a supraomohyoid dissection for the contralateral side, sir.
So what are the various types of the modified radical neck dissections?
Modified radical neck dissection will be of 3 types. In all stages, 1 to 5 level lymph nodes are taken, and then structures preserved in type 1 will be the spinal accessory nerve. In type 2 MRND, the nerve and the IJV will be preserved. Although there is controversy in this, whether the vein will be preserved or the muscle will be preserved. Type 3, all 3 structures will be preserved, sir. The spinal accessory nerve, sternocleidomastoid, and the IJV, sir.
Okay. Now for, what is a commandos operation?
Yes, sir. It is combined mandibular resection and nodal dissection. That is the expansion of the tongue, but it is to excise the tumor with the neck nodes, and the mandible will be resected, sir. Planned with reconstructions.
So if you have to excise the floor of the mouth,
Yes, sir.
then how you are going to reconstruct that?
Sir, pectoralis major flap will be used for reconstruction, sir.
So what should be, the basis of using the pectoral flap or the deltopectoral flap?
So it will be the vascularity will be maintained. It will be a pedicle flap, sir.
Mm-hmm. It will be a pedicle flap.
Yes, sir.
It should be associated with the hairs, or no hairs should be there?
There will be hairs, sir. I'm not sure.
It should be non-hairy, otherwise the hairs will grow in the mouth. So if you look right at the lateral part and the acromion area, if you look there, that is in almost everyone is hairless.
Okay,
you will get the hairs everywhere, but in that particular area, it is hairless, and that particular skin is taken to make the floor of the mouth.
Yes, sir.
Okay. Any other way you can reconstruct apart from that?
Free flap from the radial muscle can be brought here and then anastomosed, sir.
Take the radial flap, yes?
Yes, sir.
Okay.
What is segmental mandibulectomy and marginal mandibulectomy?
Segmental. Sir, in segmental mandibulectomy, the entire vertical portion of the mandible is removed, sir. And the marginal mandibulectomy, only a portion of the vertical this thing, and continuity is maintained.
It is conservative mandibulectomy.
Yes, sir. Okay, sir.
Another terminology, conservative mandibulectomy.
Yes, sir.
In which case you cannot do a marginal mandibulectomy?
If there is previous radiation or if there is history of osteoradionecrosis that has happened in the past.
Mhm.
I can't
In the
remember the other one, sir.
In the edentulous, if
Edentulous.
there are no teeth
Yes,
are
sir.
there,
Yes, sir.
so in that the vertical height of the mandible becomes quite less. So you cannot do a marginal mandibulectomy there.
Okay, sir.
What is the best investigation to know if mandibular canal is involved or not?
CT, ma'am.
No, you need to do an MRI to know that. CT will tell you about the
Okay.
the
Mandible.
calcified part of it. Yeah.
Okay. Yes, ma'am.
What is reverse marginal mandibulectomy?
Ma'am, not heard. I have to read.
So when the lower border of the mandible is maintained, it's marginal mandibulectomy.
Yes,
When
ma'am.
the upper border is maintained, it is reverse marginal mandibulectomy.
Okay, ma'am. Okay.
You had earlier said that you will do an FNAC from the lymph node.
Yes,
If
ma'am.
the FNA report came as inconclusive, would you not do a lymph node dissection?
I would do, ma'am.
So then how does FNA help you?
So if FNAC is positive, we can directly plan for MRND. If because
So nowadays, usually you talk in terms only of selective node dissections, and you would tell the lymph node levels that are removed. It's not that you will go in straight away for MRND based on FNA report.
Okay, ma'am.
I stand corrected, Dr. Khanna, sir. Am I audible? Are others there?
Yeah.
Yeah.
Okay. So
I stand corrected. Do you do MRND and do you do an FNA to be able to consider MRND?
not really, yeah. Because in the CA tongue and the floor of the
Yes.
mouth, you have to go for the
Neck
So it is-
dissection and
yeah.
selective block
Yeah.
dissection.
Selective. Okay, ma'am.
Okay, Priya. Then after you have done that, anything further?
Sir,
When you're doing the neck dissection and you find that the carotids are exposed,
yes, sir.
what do we do for that?
It's covered by sternomastoid muscle.
Which muscle it is that?
Sternocleidomastoid, sir.
No, that you have removed, isn't? Sternocleidomastoid you have removed in the neck dissection. It's the levator scapulae.
Okay, sir.
Levator scapulae is the muscle which is used to cover that.
Okay, sir.
In case it is exposed and you are having a, that probably the patient may have a carotid blowout.
Yes, sir.
So one thing is that what are the various ways to prevent the carotid blowout?
One is to ensure that it's not exposed before closing.
Not completely bare that, na?
Yes, sir. Okay.
One, yes. What else?
Sir, don't know, sir.
When you are raising the skin flaps.
Yes, sir.
Okay. What are the various ways to make the skin flaps? What are the various incisions which are used?
Yes, sir. Modified Kryle's incision will be a C and then a vertical limb to it in the middle.
Right.
And McPhee will be two incisions separately, one just below the mandible and one lower in the lower part of the neck.
Yes. And what is Hayes-Martin? Have you heard the name Hayes-Martin?
I have heard, sir, but I can't think of the shape of the incision. I'm not sure.
Okay,
I've not
especially
seen
in the Hayes-Martin where there are 4 flaps are there.
Yes, sir.
Superior, inferior, lateral, medial. There are 4 flaps which are there.
Okay, sir.
So in that, especially when the central part of that, where all the folds they meet there, that is the site of usually the skin necrosis.
Necrosis, yes, sir.
And once there is skin necrosis, there can be infection and there is more chance of having the blowout.
Okay,
So
sir.
when you're making these flaps, you must be sure that skin
It is
flap does
covered.
not necrose.
Sure.
If the necrosis is there, then there is necrosis
Answer.
and infection that can lead to that.
Yes, sir.
This is commonly
what is
asked
it?
question for PGs. PG exam. This is commonly asked question. What are different neck
Incision.
incision?
Yes, sir.
What are the indications and complications of the different neck incisions?
Okay, sir.
So what is the difference between the right side neck dissection and the left side neck dissection?
Sir, don't know, sir.
What extra structure which comes on the left side, which is not there on the right side? And you get
Thoracic,
extra complication on the left
thoracic
side.
duct, sir.
Yes, thoracic duct.
Yes, sir.
So you can get a chyle coming
Chyle
out
leak.
from there.
Yes, sir.
Chyle leak may be there on the left side. What is the place of neoadjuvant treatment in the case of oral cancer?
If for T1 and T2, an upfront radiotherapy can also be considered, sir.
So do you think radiotherapy will be used as a neoadjuvant or it will be a curative one in T1, T2?
Sir,
You understand what is neoadjuvant?
Yes, sir. Before surgery, if it's done before surgery. But for T1, T2 lesions, and if the nodal status is negative, then I think results are comparable to surgery. RT and surgery results are comparable.
So in the case of the CA tongue, if you have to give the curative radiotherapy, how
Yes,
will you
sir.
give that? How will you give that?
Yes, sir. 60 gray in 30 to 35 fractions.
So you will prefer the external teletherapy for that? For the CA tongue?
Brachytherapy and teletherapy. Sir.
Brachytherapy will be definitely better, you know?
Yes, sir.
So you do a brachytherapy for that.
Yes,
that
sir.
will be much better than that.
Yes, sir.
Okay. So tell about the neoadjuvant. What are the conditions where you will give the patient neoadjuvant?
If it is early disease, if the stage of the disease, tumor size is T1 or T2 with nodal status clinic negative, sir, then RT can be considered as neoadjuvant. Or if the patient
That's not
is...
the neoadjuvant. That's what I'm telling you. No? Neoadjuvant will be only for like if it is an inoperable tumor is there.
Okay.
Or you are not able to dissect that. Then only you want to shrink the size of the tumor. Then only you go for the neoadjuvant. But otherwise, in the T1, T2 lesion, you can go for the curative therapy. There is a definite difference between neoadjuvant and the curative one.
Okay, okay.
What is commander's operation?
Sir, combined mandible and nodal dissection operation, sir. It is to excise the tumor with nodal dissection and mandibulectomy, sir.
Okay.
Any special ways to
The
maintain
structures are
airway?
removed in supra.
Sorry, ma'am.
Any special technique to maintain or precautions that you take to maintain airway after tongue resections? Say after glossectomy, semiglossectomy, or
keep the patient propped up in the post-operative period.
so you may need to take consent for tracheostomy and total glossectomies.
Yes, yes, ma'am.
You may keep the patient intubated for at least 24 to 48 hours. There are
Yes,
some
ma'am.
who may even fix the tongue, the remnant tongue,
Yes, ma'am.
to the anterior part of the mandible to
Yes, ma'am.
prevent it from falling back.
Yes, ma'am.
What is the access to the floor of the mouth? How do you reach the floor of the mouth? So it may be
a mandible separating.
Yes, it may be a direct intraoral access or a mandibular split.
Split incision. Yeah. Yes, ma'am.
Where is the mandible split or cut?
In the ramus, ma'am.
No.
No, sorry, ma'am. I haven't seen.
Very rarely a midline split is done. Otherwise, it can be done where the lateral part of the chin crease is there.
Okay.
Anterior 1/3 and lateral 2/3.
Okay.
That's the thinnest part of mandible which can be.
Okay. Okay.
Yeah, so you were talking about chemoradiation.
Yes, ma'am.
Should it be given together? Should it be given alternately or?
First, RT is given and then.
So it's not sequential. Usually chemoradiation is given together.
Okay.
Dr. Kanagal, can we go to the next case now?
Yeah. Yes, sir. Complications of MRND, we've already talked about some plaque necrosis and leaks and all. Yeah. Well done, Jane.
Thank you.
Dr. Kanagal? Can we go to the next case?
Questions? Sorry, sir.
No, can we move to the next patient now?
Yes, sir. Yes, sir. Definitely, sir. I think Arjun from KIMS Hubli, he is kindly contributed by Professor Ishwar Hosamani. Arjun, are you comfortable? Can you share your PPT?
Yes,
Jane,
sir.
you have to unshare Jane now. Yes, you are good to go. Make it full screen, Arjun. Faculty, please take over. Thank you.
Good evening, sir. Myself, Dr. Arjun, postgraduate student from KIMS Hubli. And I am guided by Dr. Ishwara Rosmani, sir, professor and unit chief of KIMS Hubli. And Dr. Gurushanta Payalagachin is the professor and head of the department of my institute, sir. Shall I continue with case, sir?
Please proceed.
Yes, sir. A 74-year male, Mr. X, a farmer by occupation, hailing from Kalgatti, came with complaints of swelling below the right ear since 5 years and complaints of swelling in the lateral aspect of right neck since 5 years. History of presenting illness. Patient was apparently all right 25 years back, after which he noticed a swelling below the right ear, which was insidious in onset, initially smaller in size and gradually progressed to present size, increasing in size, for which he was admitted and was evaluated and operated for the same in the year of 2004. And after getting operated, he was free from the swelling for 1 year. And again, the swelling recurred within 1 year of the getting operated. And so was again operated consequently in the year 2010, 16 and 18 for the complaints of recurrent swelling after surgeries. So last surgery was performed at 2018, and along with the surgery, patient was advised for radiotherapy, but patient couldn't continue his treatment. So now he presented with the swelling below the right ear for past 5 years, which was which was insidious in onset, initially smaller in size and gradually progressed to present size. He also noticed a swelling, another swelling in the lateral aspect of right side of the neck 5 years ago. Insidious in onset, initially smaller and gradually progressed. Both the swelling occurred at the same time. There is also a history of deviation of angle of mouth to the left side. There is no history of difficulty in closing eyes or watering from eyes. No history of drooling of saliva from the mouth. No history of spillage of food from mouth while eating. No history of any other swelling in the neck. No history of increase or decrease in size of swelling with chewing. No history of pain while swallowing or chewing. No history of ear pain. There is no history of restriction of mouth opening. There is no history of loss of appetite or loss of weight. And for the past history, he has no comorbidities. And there is a family history also is not significant. Coming to the personal history, patient is a vegetarian in diet. He is a chronic betel chewer for past 40 years. He is a non-smoker and non-alcoholic. So coming to the summary, here is a 74-year-old male, farmer by occupation, presented with painless recurrent swelling over the right parotid region, along with the swelling over the right side of the neck, with history of facial nerve involvement.
With history suggests facial nerve involvement. What
Yes.
are the points? Go to the first slide.
Yes, sir.
Next.
The swelling is for 5 years or 25 years?
Actually, first swelling appeared 25 years back, sir, for which he was admitted and operated multiple times. But the current swelling has occurred for the last 5 years.
Mhm.
Repeat this.
Yes, sir.
Repeat again, please. First slide. There is history of swelling from last 5 years.
Yes, sir. Now he presented with the history of swelling for the past 5 years, sir. But similar swelling occurred 25 years back. So for that, he was operated 4 times. The last surgery was done in the year 2018. But immediately after surgery, within 6 months, again he developed a small swelling, which gradually progressed to the present size, sir. So for the past 5 years, he is having the swelling.
So there are 2 swellings are there.
Yes, sir. 2 swellings are there, sir. Both the swelling appeared for the past 5 years, sir, after surgery.
But it was not, the second swelling was not there before.
Not there before, sir.
Okay. Go to the next slide. When it started, how big was the swelling?
Initially smaller size, sir. The patient gave history like a peanut-like shaped one, but then it was gradually progressing.
And whenever he had the recurrence, how big was the swelling at that time?
Previous recurrences, sir.
Yeah.
Previous recurrence, I couldn't get the history, like a patient was not explaining properly, sir. But the previous swelling was comparatively lesser compared to this size.
So what went wrong in this patient? Why he was having the recurrent swellings in the same area?
Sir, maybe because of inadequate surgical excision or spillage of the tumor, if possible, could have records.
So why the pleomorph, though it's a benign condition, are likely to recur?
It has like a finger-like projection, sir, which penetrates the pseudocapsule. So if it is inadequately removed, that tumor spillage and recurrence is more common. It has pseudopods, sir.
So what is the minimal surgery which should be done for the pleomorphic adenoma?
Depends upon the tumor size, sir. The extracapsular dissection is the minimal applicable surgery if the tumor size is less than 2 centimeter.
But what is, like a gold standard for a pleomorphic adenoma, the superficial lobe?
Superficial parotidectomy, sir.
That is the gold standard.
Gold
But
standard.
because if you are not able to, you are scared of the facial nerve, then you can go for all this. But otherwise, the gold standard is the superficial parotidectomy.
Yes.
Okay. Go to the next slide. History of deviation of angle of mouth to left side.
Yes.
When did it occur? In the last surgery?
Last surgery.
Hmm?
After the last surgery.
There is no history. So what does that mean? Which branch has gone?
Buccal branch of the facial nerve may be injured, sir.
Why the buccal branch will lead to deviation of the angle of the mouth?
Branch, maybe.
What are the various branches of the facial nerve?
So 5 branches, sir. Temporal, zygomatic, mandibular, buccal, mandibular, and cervical.
So which branch will out of these will lead to deviation of the angle of the mouth?
Marginal mandibular.
Marginal mandibular, not the buccal.
Sir.
If the buccal is damaged, what will happen?
Atrophy, either that blowing of mouth, buccinator muscles, maybe.
Blowing of the mouth is one.
Sir.
And what about the food?
Spillage of food will be there.
No, it will be getting collected in that area because of weakness in that area.
Yes.
Okay, the food will get collected in that area.
Yes, sir.
Okay. So out of these 5 branches, if you have to save one branch, which one you will save?
Temporozygomatic branch. Temporozygomatic branch, sir. Temporozygomatic.
In the temporozygomatic, which one you like to save?
Zygomatic.
Zygomatic. Why you want to save the zygomatic?
To control ophthalmic problems. To protect the eyes, sir, from exposure keratitis and
corneal ulcerations, and ultimately the patient may become blind because of that.
Yes.
So that is the most important branch which you have to save.
Yes.
Arjun, what are the branches of facial nerve within facial canal, distal to the stylomustard foramina, and within the parotid duct, within the parotid gland? What are the branches within facial canal?
Facial canal, one of the branch will be nerve to stapedius, sir. And
greater petrosal nerve, chorda tympani, greater petrosal,
tympani,
and
yes.
auricular branch. These are the 4 branches.
Yes, sir.
And leaving distal to the stylomustard foramina?
It divides into two trunks, sir. Temporozygomatic and cervicomandibular branches, sir. Temporozygomatic gives to temporal zygomatic, and lower trunk give rise to buccal, mandibular, and cervical.
Nerve distal to the stylomustard foramina before entering the parotid gland. These are posterior auricular nerve and nerve supplying styloid and posterior belly of the digastric muscle. How will you differentiate between upper motor neuron lesion and lower motor facial palsy? Upper motor facial palsy, lower motor facial palsy.
Lower motor will involve this. First of all, either occipitofrontalis muscle will be spared, sir, and then upper motor neuron will involve the ipsilateral sides. Contralateral sides, sir. Lower motor and ipsilateral sides.
No. In lower motor, complete unilateral impairment will be there.
Yes.
And in upper motor, lower face, weakness of only lower face. Okay, proceed.
Go to the next slide. So what is the significance of no history of increase or decrease in size of swelling while chewing?
Condition like sialidinitis and sialolithiasis will have an increase or decrease in size with chewing, sir, because of secretions.
Sialolithiasis is more common in the parotid gland or in the
submandibular gland, sir. Submandibular gland.
Why? Why it is more common?
Because the secretion is thick and viscid, and because of anti-gravitational secretion, and also lingual nerve encircles the Ortin duct, sir. So there will be stasis and formation of stones.
No history of pain while chewing.
Yes, sir.
Why is that?
For any sialidinitis condition, will have pain, sir, mostly with moving.
Okay. Ear pain?
Ear pain, any radiating pain involving glossopharyngeal nerve may have a radiating pain, sir. If you suspect a malignancy, if it is involving the nerve, it might have a radiating pain, sir.
Restriction of the mouth opening?
If it involves the pterygoid muscles or TMJ joint, temporomandibular joint, there will be restriction of mouth opening.
In your patient, if there is a mouth restriction is there?
No, sir. There was no.
What may be the cause? No, what may be the cause for that in your patient?
Maybe it might have involved the pterygoid muscles, sir.
Any other reason?
Involved temporomandibular joint.
You know, he's a smoker and he's also taking canny or something, or he's taking some quid?
Only betel nut chewers, a non-smoker.
Betel nut chewing. No? So betel nut chewing will lead to what?
Submucosal fibrosis.
So that can also lead to the restriction of the mouth opening.
Yes, sir.
So not necessarily it is because of the tumor,
yes, sir.
But because of that also the patient may have the restriction of the mouth opening.
Yes.
Right. Okay, next slide.
Both the past and family history are not significant.
So does the parotid tumor run in families?
Parotid. It is like mostly for differentiating, sir. If we suspect like lymphoma, parotid tumors usually doesn't runs in families, sir. And
sometimes you can have the familial also. No, very rare, but it can be there.
Yes.
Okay. Right. Go to the next one. Patient is chronic beetle nut chewer for 40 years, non-smoker, non-alcoholic. Madam, you want to ask any question, Dr. Ratna?
I have a suggestion to make to Dr. Arun. Dr. Arun, you seem to be answering well, but then your presentation is a bit against the norms in the sense that you could have started your chief complaints
Yes, ma'am.
from the first time that he had a parotid swelling, and then written separately that the presenting complaint this time was swelling for as many years. Then in your first slide only, you had to be questioned as to what was the size of the swelling and how much is it now. You could have mentioned that patient had a swelling roughly as many centimeters as gestured by him and has progressed to the current size now. You could have shown us the image of the swelling also, right?
Yes, ma'am.
Yeah.
Actually, I have attached the image, ma'am, but my history could have been better. Yes, ma'am.
Yes. So that way, the sequencing could have been made better.
Yes.
Then you should have also told us that what were the post-op problems that happened after, especially the last surgery that he underwent. Because you've made a mention that there is history of facial nerve palsy,
Yes,
but
ma'am.
we do not know whether it is a post-surgical problem or did he develop facial nerve palsy after he developed the swelling again. That is not very clear from your history.
Yes, ma'am. Yes.
Have you written it anyway that after the swelling developed, he's developed a facial nerve palsy? Or is it that after the last surgery, he had a palsy?
No, ma'am, I haven't mentioned that.
So that
Correctly.
you should specifically
Yes.
mention. Then you have mentioned that he has another swelling in the neck also
Yes.
in your history in the beginning. But thereafter, when you are continuing, you have written no other swelling in the neck.
I mean, it's contralateral
Go
side.
back to the previous slides. You can't be writing contentious statements, no? Previous slide, I think somewhere you've written no history of any other swelling in the neck. So
Yes.
where is the second swelling if it is present, if there is no other swelling in the neck? It must be in the neck only, no, the second swelling? Or are
Yes,
there
ma'am.
multiple swellings in the parotid area?
Parotid area one swelling and one more swelling in the right lateral side of neck.
So then
I
you
was
can't
about
write
to
no
mention
history of,
contralateral side.
yeah. So I think you've accidentally written. So you have to be a bit careful when you are writing.
Yes, ma'am.
Right? Let it be a flow of thoughts in a proper sequence. Yeah. So I think we can proceed to examination. What history did you ask in no significant comorbidities? What comorbidities did you ask for?
Like any tuberculosis history.
See, besides all these, you must also ask if there is any history of dryness of mouth and eyes, because Jorgen syndrome can be there, which can involve.
Yes.
Yeah. Proceed to examination.
Coming to the general examination, patient is moderately built and moderately nourished, and there is no pellar, no icterus, no cyanosis, no clubbing, no lymphadenopathy. Patient is conscious and oriented, and the vitals are pulse rate 82 beats per minute, blood pressure is 120 70 millimeter mercury, respiratory rate is 18 cycles per minute, and saturation maintaining in room air. Coming to the local examination inspection, a swelling of size approximately 10 cross 10 centimeter noted in the right parotid region, is globular in shape, extending anteriorly up to 3 centimeter from the angle of mouth, posteriorly 6 centimeter from the occipital protuberance, superiorly up to zygomatic arch, and inferiorly 3 centimeter below the angle of mandible. The surface appears smooth, skin over the swelling appears normal, the borders are well defined, and there is a surgical scar seen over the swelling. The right ear lobule is raised above. Coming to the second swelling, there's another swelling of size of 4 cross 6 centimeter, elliptical in shape, seen in the lateral aspect of the right side of the neck. Surface appears smooth, skin over the swelling appears normal, extending superiorly up to inferior border of the previous swelling, and inferiorly 6 centimeter above the clavicle, anteriorly 6 centimeter from the thyroid cartilage, and posteriorly 6 centimeter from the occipital protuberance. Palpation, swelling of size 10 cross 10 centimeter noted in the right parotid area, globular in shape. Extension is same as previously mentioned, anteriorly up to 3 centimeter from angle of mouth, posteriorly 6 centimeter from occipital protuberance, superiorly up to zygomatic arch, and inferiorly 3 centimeter below the angle of mandible. The swelling is hard in consistency. Borders are well defined. Surface appears smooth. Skin or the swelling is pinchable. And moreover, there is no local rise of temperature, and it is a non-tender. And coming to the second swelling, the swelling of size 4 cross 6 centimeter, which is elliptical in shape in the right side neck at the lateral aspect. Surface is smooth. Skin or the swelling is pinchable, freely mobile, extending superiorly up to inferior border of the above described swelling. Inferiorly 6 centimeter above the clavicle, anteriorly 6 centimeter from thyroid cartilage, and posteriorly 8 centimeter from occipital protuberance. There is no local rise of temperature. It is non-tender, firm in consistency, well-defined border, smooth surface. Skin over the swelling is pinchable. Platysma sign is negative. This is the picture of the patient. Examination of the oral cavity. The mouth opening is adequate. Opening of the parotid duct is normal. There is no erythema or no discharge seen at the opening of the duct. No bulge of the tonsillar fossa. There is no deviation of the soft palate. And on palpation, bimanual examination is done, and there is no involvement of the deep lobe. And bidigital examination of the parotid duct is done. There is no palpable stones. Examination of the facial nerve. Facial asymmetry is noted. Wrinkling of forehead is present on both sides. There is no difficulty in closing of eyelids. Deviation of angle of mouth is present towards the left side. Patient is unable to whistle or blow. And examination of cervical lymph nodes. There is no palpable lymph nodes.
Have you completed the examination?
Yes, ma'am.
Did I miss, or you haven't spoken about this? Is the local regional examination that you've given us, or?
And systemic examination is there. CBS, S1, S2 heart sounds are here, and respiratory system, bilateral air entry is present. There are no added sounds. Coming to the CNS examination, there is no neurological deficit, and abdomen is completely soft. So with that, it completes my examination.
Did you tell about your second swelling you were telling? Have you told about that?
Yes, sir, I have mentioned, sir.
Just show the picture again.
Yes.
Okay. Did you check for the deep lobe here?
Yes, sir. With the bidigital examination, I have confirmed, sir, there is clinically there was no involvement of a deep lobe, sir.
So where do you see for the swelling for the deep lobe?
In inspection, I would see for the bulge of the tonsillar fossa. If it is bulged medially, there is the involvement of deep lobe. And for the palpation, I will palpate at the retromandibular areas for the deep lobe involvement.
So it's a bidigital examination. So where do you keep your digit outside?
Thumb will be in inside, sir, and all the other four will be over the swelling at the outside.
Over the swelling? So can you find out
the,
what is the over the swelling?
mandibular areas.
Hmm?
Yes,
What
sir?
is that called as, that area?
Yes, sir. Sorry, sir.
What is that area called as?
Retromandibular area.
Retromandibular sulcus.
Sulcus, yes.
Okay, that is a sulcus. You put your digit there at the retromandibular sulcus for that.
Yes.
Okay. What is the parotid region?
Parotid region is bounded anteriorly by the posterior border of mandible and posteriorly by the mastoid process and sternocleidomastoid, superiorly by the zygomatic arch and inferiorly by the posterior belly of digastric muscles.
Okay. What is the anatomical landmark for the parotid duct?
It is between the line joining the tragus and another line joining midpoint of ala and the angle of mouth, sir. In this line, medial 1/3 will be the location of the parotid duct.
Medial 1/3 or middle 1/3?
Middle 1/3 maybe.
Middle 1/3 will be the
Middle.
location. What is curtain sign?
The superior border of the swelling won't be crossing the zygomatic arch, sir.
Why is that?
Because the deep cervical fascia, before entering the gland at the apex, it gets divided into two laminas, and the deeper lamina, which is thicker one, will get will insert at the zygomatic arch, sir, so that the swelling cannot grow upwards.
What are the various causes for bilateral parotid tumor? Parotid swellings rather than tumor, parotid swelling.
Depends upon age, sir. If patient is of like pediatric age group, if history of fever is there, I would suspect viral infection like mumps and infection by Coxsackie virus. And if the patient is an adult and chronic alcoholic, I would think about sialadenitis. And if the patient oral hygiene is poor, I would suspect sialadenitis secondary to bacterial infections.
Okay. Any tumors of the parotid which can be bilateral?
Watkins tumor may be bilateral in elder ages.
Any other tumor which can be bilateral? Lymphoma?
Lymphoma, yes.
Lymphoma can be bilateral.
Yes.
So what is this second swelling which is there? What do you think? What is that second swelling?
So considering the etiology and I would suspect like at the time of last surgery, there might be a tumor spillage which causes a seedling and occurrence of the second tumor. So second swellings.
So is that a lymph node or not?
Not a lymph nodes.
How can you be sure that it is not the lymph node?
Yes, sir. It's a freely mobile swelling, sir, without any restrictions. So, and it's also more superficial. So, like unlikely to be a lymph node. And it is also not a
nothing like a freely mobile here. Okay.
Yes, sir. Yes.
Nothing like a freely mobile in the neck. Does it move with the same swelling together, or it is?
Yes, sir,
mobility is different.
Different, sir. A cleft is there, sir, in between.
There's a cleft is there in between.
Yes, sir.
So you have to consider the lymph node also here, is it?
Okay.
What is the relationship of the swelling to the scar? Is it fixed to the scar? Both the swellings. How are they related to the scar?
The scar was seen only in the above swelling, ma'am. And at that region, it was indurated. So I couldn't make out that. I couldn't get that skin pinchable over that scar.
Yeah, and the lower swelling?
Lower swelling has no related scar, ma'am.
Because this is the area where scar is expected to be
Yes, ma'am.
for parotidectomy. So if you are saying it is not related to the scar, it is difficult to believe. If you can zoom the picture and show us where the scar is. I think scar should be exactly where the cleft is. And scars are the common sites where recurrences usually start.
Okay, ma'am.
We can see two more nodules below the swelling that is seen, the smallest swelling. Is it just...
Sorry, ma'am, I couldn't appreciate.
No, we can see two small nodule kind of things. Maybe it's just because of the image that you've taken. Some kind of reflection is happening. The only thing is that palpate properly to rule out if any lymph nodes are enlarged or not. Did you mention the consistency of the swelling? Is it uniform all through, or is it
Yes, ma'am.
variable?
It is hard in consistency, ma'am, that above
All
swelling.
through, and it's uniformly hard in consistency?
Uniformly hard in consistency.
So when you said the lower swelling is freely mobile, you meant to say it is freely mobile in the subplatysmal plane, or you meant that it is freely mobile outside the skin?
Sorry, ma'am.
What did you mean by free mobility of the lower swelling?
Deeper structures are not involved, ma'am. Like
No,
muscle
but is the
involvement.
platysma involved? Is it superficial to the platysma? Is the swelling deep to the platysma and the muscles, or what? What is the
It is
relationship of the
superficial.
swelling to sternocleidomastoid?
On tauting the sternocleidomastoid muscle, there is no restriction of movement.
Okay. It's superficial to the sternocleidomastoid
Superficial,
and it's
yes,
mobile over it. Right. What about trapezius?
Trapezius, I didn't examine here.
You should have examined, no? Because this is also the area where accessory nerve is present.
Yes, ma'am. Yes.
You have to, yeah. So most likely this is a parotid nodule only that we are thinking in terms of. If there were a lymph node that were enlarged in this area, like Khanna sir was saying, which level lymph node would it be?
A level 3.
Not at all.
Okay. Maybe a level 2.
Of course not. It is present at the apex of trapezius in posterior border of sternocleidomastoid. It seems to be in the posterior triangle. It seems to be in the upper part of the posterior triangle, maybe encroaching onto level 2 also. So it would be level
5.
5A.
Yes,
Okay.
5.
Yeah. Yes. So, so what are the sites that you looked for metastasis?
Sites of metastasis. Usually pleomorphic adenoma doesn't metastasize to any organs, ma'am. And lymph node spread is also very rare.
No, the thing is, you're thinking of a malignant swelling, no? So it could be a malignant parotid lesion to begin with that has recurred so many times. It could be a pleomorphic adenoma that has recurred, or it could possibly be malignancy that has arisen in a pleomorphic adenoma. So which out of these three do you think is it?
I would think like it's a recurrent pleomorphic adenoma.
So what do you think is the reason for facial nerve palsy in a recurrent pleomorphic adenoma?
The recurrent nerve palsy, maybe because facial nerve palsy, maybe because of the previous surgery.
That's what, that's where history makes a huge difference in this,
Yes,
to reach to a diagnosis, right? How will you manage this case? Any possibility of malignancy, or you want to entertain only one diagnosis, and that is pleomorphic adenoma?
Considering with history, there is no suggestive of history and examination doesn't suggest of any carcinomatous changes, ma'am. Like any possibility of carcinoma.
No, but you've got two nodules here, even though they are mobile. And there is such a sudden increase in size of this nodule also. Multiple recurrences are known to happen in pleomorphic, and recurrent pleomorphic adenomas are known to undergo a malignant change. In this particular case, there seems to be a sudden increase in size of the swelling also. So you should entertain a differential diagnosis. In fact, if I were you, I would have kept a first diagnosis as maybe a malignant change in a pleomorphic adenoma.
Yes, ma'am.
How will you manage this case?
First, I would like to do investigations to confirm my diagnosis, ma'am.
What investigations will you do?
First, I would go for non-invasive investigations like ultrasound, ma'am. Obviously, to confirm the diagnosis, I would like to go with ultrasound, ma'am. Other than routine
ultrasound? In this case, it's a recurrent parotid swelling. Do you think ultrasound per se will give you, it's easily available, you can get to know something that is different, but otherwise, do you think ultrasound should be the investigation of choice in this case for confirming diagnosis?
Confirming diagnosis, since it's a recurrent, I would like to go for first like FNAC. Invasive investigation of choice will be FNAC.
Yeah. Maybe you can say you want to get an ultrasound done because you want to take an ultrasound guided
FNAC.
needle aspirate from it for cytological examination, right?
Yes, ma'am.
But otherwise, you would want a CT or an MRI in this case. Why?
To look for the bony involvement or any perineural.
Bony involvement, you don't really expect. You said it's a freely mobile swelling.
I would like to go for MRI, ma'am.
What are the other areas where this swelling can extend? From the parotid area,
yes,
what are the other areas where this swelling can extend if it were a malignant swelling?
Underlying bones.
Okay.
If it there might be the perineural invasion also, ma'am, to the stylomastoid foramen.
Okay, one is that it can be by direct invasion, and then there can be direct extension also into the temporal areas, the parapharyngeal areas.
Yes, ma'am.
Right? How do you get to know about neural involvement on MRI? Do you get to see nerves on MRI?
Soft tissues and nerves could be appreciable in MRI.
So nerves are not appreciable. You get to see the vascular changes, which are indirect evidence of involvement of nerve.
Okay.
Right. So it is such a large swelling. You would want an FNAC from this? Or would you want a core needle biopsy?
Core needle biopsy, mostly not followed in parotid.
Why not?
Maybe because of tumor seedling and facial nerve
Tumor seedling
damage.
nerve involvement can happen.
Involvement, yes.
What else will ultrasound tell you? You wanted to do the ultrasound? Other than the swelling and the characteristics of swelling?
Could appreciate the deep lobe involvement.
Maybe with high frequency, otherwise it's difficult to make out. Yeah. Anything else that ultrasound can tell you?
An area of necrosis or...
So one is the characteristics of swelling, like I said. Another is extent of invasion into the adjoining areas. Third thing would be you would also want to look for any other enlarged lymph nodes in the neck, right?
Yes.
So the biopsy comes as malignancy in a pleomorphic adenoma. How will you manage further?
Directly, surgery is the treatment of choice, ma'am.
So then you may want to stage the disease. After you've confirmed the diagnosis, you would want to stage the disease also,
Yeah, yes, ma'am.
right? You would want to do a metastatic workup, no?
Metastatic workup, yes.
So that shows that there are no metastases anywhere in the chest or elsewhere, right?
Yes.
You've
Yes.
done a PET CT also, and there is no metastasis anywhere. How will you manage this case?
I would like to proceed with surgery.
What surgery?
Suspecting carcinomatous changes, if there, I would like to go for a total, I will try for total conservative parotidectomy, ma'am.
What is the difference between total conservative parotidectomy and radical parotidectomy?
Total conservative, I will preserve the facial nerve, ma'am.
Yeah.
Yes. In total radical, full.
But you don't want to address the lymph nodes in the neck?
Ma'am, sorry, ma'am.
You don't want to address the lymph nodes in the neck?
Lymph nodes, I couldn't palpate any lymph nodes, ma'am.
Yeah.
So I don't think any neck dissection will help in this patient.
So to my mind, in malignancy, you should do an R0 resection with total conservative parotidectomy and modified radical neck dissection,
Okay, ma'am.
especially with recurrent markers. We can ask Dr. Khanna sir also what he has to say to it. And plus, you may need to reconstruct the defect that is created. An extent of R0, supposing there is regional, you see that the ear lobule is lifted up, and I told you it's a malignant swelling. So what will you do to the pinna in this case while you're doing a total conservative parotidectomy?
It can be conserved, ma'am.
No, so radical parotidectomy, all the adjoining structures which are involved have to be removed till you get a R0 resection. It may mean removing a part of either pinna or auditory canal or
Okay.
other structures, yeah. So,
Arjun, if you want like a pleomorphic adenoma, you are planning for the superficial parotidectomy.
Yes.
How do you drape your patient?
In a supine position with the neck tilted to the opposite side, I will paint and drape, exposing the angle of mouth of the ipsilateral side, sir.
Only the angle of the mouth?
Yes, sir. Angle of mouth. I think I have no idea, sir.
Outer canthus?
Yes, sir.
Outer canthus has also to be exposed, you know, because that is much more important.
Yes, sir.
What is this technique called as?
No, I didn't know, sir.
This is called as a Hopsley technique. You know?
Okay, sir.
Hopsley technique of draping your hair.
Yes.
Okay. So plan your incision now.
I would go with Blair incision, sir. Laziest incision, starting from the tragal point, curving down towards the mastoid process.
How much anterior to the tragus?
1 centimeter.
As less as possible, you know? So maybe just the 5 millimeters.
Okay, sir.
Because this is for the cosmetic reason, Joel.
Okay, sir.
Okay, then?
Then I would extend down and curved up to the mastoid process and proceed down to the angle of mandible, sir.
So when you are making an incision below the mandible,
yes, sir.
How much you should be below?
2 centimeters, sir.
Why that? Why 2 centimeter below?
Because marginal mandibular nerve comes 2 centimeter below the angle of mandible, sir.
Right. Okay. To preserve the marginal mandible.
Yes, sir.
Right. Then, how do you raise the flap?
Posteriorly, up to sternocleidomastoid, sir, and anteriorly up to masseter muscle, posterior border of masseter.
So on the sternocleidomastoid, do you get any nerve there?
Accessory, spinal accessory nerve.
No, you don't get that in that area.
How will you locate facial nerve intraoperatively?
By the Conley point, sir. The Conley point is the junction of cartilaginous and bony junction of the external auditory canal, sir. This is the first landmark, and other than that, to locate the posterior belly of digastric muscle, and exactly 1 centimeter above the muscle, we'll get the facial nerve, sir. Or we can palpate the styloid process, and lateral to that lies the facial nerve, sir.
Okay.
You get the greater auricular nerve there, no?
Yes,
On
sir.
the sternocleidomastoid, you
Sir.
get the greater auricular nerve there. Okay.
Yes, sir. First nerve.
Any other way to look for the facial nerve? What is the retrograde way?
Retrograde wave from the individual branch, we'll trace and we'll get the trunk, sir.
What is that technique called as?
Name I'm not sure, sir, but it is most
Yes.
followed in the recurrent cases.
There's the Hamilton-Bailey technique.
Yes, sir.
Hamilton-Bailey technique of the retrograde dissection of the nerve there.
Yes.
How far you raise the anterior flap?
Up to the anterior border of parotid or masseter muscles.
Okay. And how thick should your flap?
It should be as like thicker as possible, sir, to control the flap necrosis.
Apart from the flap necrosis, what is the other reason to make a thick flap?
To control Frey syndromes.
Yes. For the Frey syndrome also. Yes. Okay. How do you dissect the facial nerve? What is Patty's plane?
Faciovenous plane of Petty is a plane where formed by the facial nerve and retromandibular veins, sir, which divides the gland into superficial and deep lobe.
There are three things which are there: nerve, vein, and the artery.
Artery, yes. Artery is deeper. Yes.
So, which artery is there?
External carotid artery.
Okay. And what is the relation of the nerve to the vein?
Vein is most superficial, sir, compared to nerve. I'm not sure.
No. I think probably nerve is superficial.
Okay, sir.
Yeah. Is it right, Dr. Ratna Chopra?
Of course,
Nerve is
sir. How will
superficial.
you dissect the nerve? Otherwise, it will be bleed all the time. If veins were superficial, nerve is superficial.
Okay.
Okay. Right. So you have done the superficial parotidectomy. What are the various complications which can occur?
Complications like recurrence is common, sir. Other than that, I would say formation of hematoma and psilocele and damage to the facial nerve and flap necrosis, Frey syndrome.
If you detect that you have damaged the facial nerve at the time of the surgery, what are you going to do?
First, we'll try for the if there is no segment loss, we can try to suture it up, sir. if there is segment loss,
You
we
have to
should go for
suture that. How will you suture?
With 80 proline suture material or finer.
You have to have the loop magnification at least, na?
Sir.
You have to have the loop magnification, and then you can suture it with the 8090 proline. Okay. Then in the post-operative period, if you find, what are the various types of injuries which can occur to the facial nerve?
Sorry, sir.
What are the various types of nerve injuries? Like a patient has got the facial paralysis
Sir.
in the post-operative period. Have you cut the nerve or not? Is it always that you have cut the nerve?
Mostly because of neuropraxia, there will be a temporary facial nerve palsy will be there, sir, which will correct on its own by over a period of time, sir.
So what are the three types of nerve injuries?
Neuropraxia, axonotmesis, and neurotmesis.
Okay. So the facial nerve damage is there. It is not recovering. And you are not able to plan for the nerve repair. What are the other options you can give to the patient?
Depends
For
upon
the eye, for the angle of the mouth.
For the eye, we can advise for carboxymethyl cellulose drops, sir.
Okay, that is
And
one.
if surgical intervention is needed, we'll go for tarsorrhaphy.
Which one, medial or lateral?
Lateral.
Lateral tarsorrhaphy, yes. Why not the medial tarsorrhaphy?
I didn't know, sir.
There's some duct there in that area. You know what is that duct?
Nasolacrimal duct, sir.
Nasolacrimal is there, no?
Yes.
So if you do a tarsorrhaphy on the medial side, that will be blocked.
Yes.
Okay, so it's always the lateral one.
Okay.
Okay. What other things can be done? Especially like for the angle of the mouth?
Facial exercise, facial massage can be advised, sir.
Okay. Any surgical alternatives?
No, sir, I didn't know.
You can put certain splints there, you know, which are with the temporalis muscle attached to that.
Okay.
Slings are there, you know, you can put the slings there. So when the patient clinches the mouth, the angle of the mouth is lifted up. Okay, so there are the various type of the dynamic sprints which are there, which can be used for that.
Okay, sir.
So
What
there
other
are this,
complications? Yeah, please, madam. Yeah.
so there are other functional repairs also. You can do some tendon transfers and pulley repairs, wherein you can take palmaris longus tendon, attach it to the angle of the mouth, and then take it via a pulley towards the eye. So every time the patient will open the mouth, the eyes will close.
Okay.
And what do you do for the Fraze syndrome?
Um,
How do you diagnose the Fraze syndrome?
There will be a gustatory sweating, sir, when the patient is chewing.
So what can you do for that?
We can advise for antiperspirant, sir, like ammonium chloride,
Right.
or anticholinergic drugs, and reassurance.
Okay. Anything else which can be done now? Any surgical treatment?
Surgical. It's a tympanic neurectomy.
So can you do the neurectomy by any other way? You can inject something there. What thing can be injected?
Botox,
Yes.
yes, Botox injection can be.
Botulinum toxin. है ना?
Botulinum
Botox
toxin.
is the trade name. है ना?
Yes, sir.
So botulinum toxin can be put in that.
Yes, sir.
And then any other thing which can be, you can put a pad of fat during the surgery
Yes.
in that area so that that area doesn't come in contact with the skin. You can do the neurectomies at the time of for the surgery. So all these are the other options which can be done further. But majority of the time, face syndrome is managed by the conservative treatment.
Yes.
Dr. Cannibal, can we call it a day?
Yeah,
Yes,
so
sir.
if you
I
have
think,
one more question, if you have this
please, ma'am.
mass, if you have this mass which is adherent to the mastoid or is occupying the whole of the retromandibular sulcus, how will you access the facial nerve? So if you're doing parotid surgeries, you have to be mentally prepared to do a mastoidectomy also to be able to trace the facial nerve from there.
Okay.
Right?
Okay.
Yeah.
Ma'am, actually, many times, if you could
Yeah.
see, bigger parotids are fairly easier, ma'am. Maybe Kanna
Yeah,
sir
yeah.
can
Yes,
supplement
yes.
that. The smaller ones and more flat lesions have
Adherent and
made our life miserable, ma'am. Sometimes getting it to the nerve
yes.
only takes 1-2 hours also. Bigger lesions, somehow or other, we always have felt that planes are much easier. Nerves are always lifted up nicely. Kanna sir, you please share, sir, bigger is tougher or smaller is
Yeah,
tougher, sir?
No, the bigger is relatively easier. जो है. Yeah, bigger ones are. The smaller one which are there right in the intraparotid area, जो है, some exotic variety, they are okay. But once it is right in the parotid gland, it is going all that. Those are the most difficult one, yeah.
Basically, the tumor is exophytic, it becomes easy, ma'am. Otherwise, if
Yes.
it is the intraparenchymal tumor sort of thing,
Yeah.
sometimes it becomes capsulated, then nerves bang cross the lesion, however small it may be, that makes our life very jittery, especially handling that. And I think the same holds with thyroid also, right, sir? Thyroid, bigger the tumors, they are much better. But infiltrating tumors are have made Hashimoto's or something sort of thing have made our lives miserable. Even they have become very small also. And anyway, I think Arjun, you share the final yield of the biopsy reports and others, so that have they given the final verdict, or how far we are getting from that?
Yes, sir. We got the final report of biopsy, sir. It's a recurrent pleomorphic adenomas.
That is all, right?
Yes, sir.
Are you subjecting for markers?
Yes, sir.
You are planning to, you have discussed with your MDT?
Sorry, sir?
You have discussed with MDT?
No, sir, not yet.
Multidisciplinary team?
No, sir, not yet, sir.
Okay.
But we are planning for radiotherapy, sir.
Okay. Then obviously it has to go for MDT. Benign lesion going for RT should have to go for an MDT. And any other doubts you have, Arjun, to ask with the senior faculty here? Now that you have read so much about recurrent pleomorphic adenomas and up till the RT part of it.
Sir, will chemotherapy help this patient, sir?
At this point, I think radiation itself is to be done only on an experimental basis.
Okay, sir.
A few benign tumors and benign recurrences which can be supported by RT. But again, RT is at the discretion of the radiation oncologist. So it is definitely need to be presented to take it. But at this point of time, I doubt chemo. Sir, Kanna sir, maybe you have a better experience. A benign thing as a chemotherapy, do we
No, I think
suggest, sir?
chemotherapy should not be given here. Chemotherapy is not. Even the radiotherapy, you have to think many times before you give that in a benign tumor. But certain like fibromatosis is there and all those things there, where though it is a benign tumor, but still the radiotherapy is given in. But chemotherapy should not be given.
Any other questions, Arjun?
No, no, sir.
Okay. Ishwar sir is joining mine. He said he will be able to join sometime later. I've not seen him at all. If
Yes.
he's busy, then call it a close.
Yes, sir. Yes, sir. I think sir is busy, sir. I have called him.
Oh, you try to speak to him.
Yes,
Okay.
sir. Yes.
Ratna ma'am, Kanna sir,
Yes, sir.
Nishi sir, you have any comments? I saw you coming and going in between. No. Okay, fine. Thank you, Kanna sir. Thank you, Ratna ma'am. And thank you, Arjun. And I think Jane has left. I think if Jane is there. Once again, thanks to you. Thanks to Professor Balaji sir and Professor C.D. Narayanan sir for permitting you to come in. And from your side, thanks Ishwar sir and Dr. Guru Shantappa Elagachin, who's the
Yes.
current HOD for permitting both the candidates here. And I thank Professor Nishikant Pujar sir, Kanna sir, Ratna ma'am for joining us this evening. And we look forward for yet another week of academics in the coming Friday. I think coming Friday, there have been already one CA parotid and we have one soft tissue tumor already up and ready waiting for it. And then we will keep updating you about how we are taking it further. Thank you very much. Kanna sir,